Today, my topic is fetal thoracic and lung anomalies. So, the fetal thorax can be thought of as a two-bedroom apartment with two tenants, the heart and the lungs. The heart often steals the spotlight with its complex anatomy and physiology, leaving the lungs somewhat overlooked. Having already discussed the celebrity tenant, the heart, in our last to last weekly session, today we will focus on the less glamorous but equally important occupant, the lungs, and the various thoracic anomalies that we encounter. So, when examining the fetal thorax, the first structure to evaluate is the lungs. Normally, the lungs appear homogeneous and are slightly more echogenic than the liver. It is important to remember that lung echogenicity changes with gestational age. In early gestation, as you see here, the lungs appear relatively less echogenic, and as pregnancy advances, they become
Dr.
progressively
Tanya,
brighter.
you can switch
Yes,
on
sir?
your video also, so that it will be more.
Yes, sir. I'm playing the video, sir.
No,
Is
no,
it not?
your video also.
Oh, okay,
You
sir.
can switch on your video also, so that what you are speaking will correlate with what is going on. Yes.
Okay, sir.
Just cut off your video will be. If you're unable to, you can continue with the.
Sir, I have some internet. Sir, am I?
Yes.
Sir, I have some internet issues, sir. So can I continue like this one, sir? I have some internet issues.
Okay. Yeah, you can look in. Yeah, should I send you the link?
No, sir. Continue, madam. Next. So is my screen visible, sir?
Your screen is visible then, yeah.
Okay. Shall I continue, ma'am? I'm audible, no, ma'am.
Yeah, you're audible.
Okay, then I'll continue, ma'am. So in early gestation, as you the lungs appear relatively less echogenic, and as pregnancy advances, they become progressively brighter. Now, this is a normal maturational process that should not be mistaken for pathology. And the second structure to assess is the thoracic cage, particularly the ribs. The ribs should extend sufficiently to cross the AV valve. Then you can say that it is of normal size and they are not short. So there is an increase in echogenicity as gestational age progresses, and ribs should cross the AV valve of the heart. It is also important to assess the fetal thymus during thoracic examination. The thymus is normally visualized in the anterior mediastinum, lying between the sternum and the great vessels, and can be identified on the three-vessel trachea view. This is the thigh box, the thymic box, showing thymus in the center and internal mammary vessels on the sides. A decreased thymic thoracic ratio may be associated with conditions like 22q11 deletion and conotruncal anomalies. So having reviewed the normal appearance of the fetal thorax, let us now move on to the common thoracic anomalies. These can be broadly classified as shown in the following slide. The lung lesions, pleural lesions, diaphragmatic lesions, airway lesions, mediastinal lesions, chest wall abnormalities, and secondary abnormalities. So coming to the most common abnormality, congenital diaphragmatic hernia. Its incidence is 1 to 5 out of 10,000 births. There is herniation of abdominal viscera into the thorax, but that particularly is not the problem. Herniation occurring between the 3rd to 16th week of lung development causes the lungs to become hypoplastic, and there is an over muscularization of the pulmonary vasculature leading to pulmonary hypertension. CTH can be of different types based on the location of the defect, and it is most commonly seen on the left-sided posterolateral part. The cause for the failure of the diaphragm to close could be genetic or environmental. Coming to the development of diaphragm, normal diaphragm development occurs during 4 to of gestation. The transverse septum initially divides the thorax and abdomen and provides the initial scaffolding from which the final diaphragm is built upon. Following formation of the pleuroperitoneal folds, the posthepatic mesenchymal plate is formed. So as the posthepatic mesenchymal plate grows dorsolaterally, the pleuroperitoneal canals are closed and the thorax is partitioned from the abdomen. The muscularization of the diaphragm is achieved by migration of the progenitor cells from the somites, leading to incorporation of the intercostal muscle with the diaphragm. The suspicion of CDH first arises when there is absent stomach in AC plane and the stomach is seen in the thorax. So it is a pretty straightforward diagnosis, which can be picked up even at 12 weeks. And the stomach bubble will be seen pushing the heart towards the opposite side. So there will be dextroposition or extreme levoposition of the heart. The problem comes when you have stomach down. So you see an echogenic mass pushing the heart to the opposite side and you're not sure if you're dealing with CDH. This is because the bowel is herniating up and the stomach is pushed down to a lower level and it takes a tubular shape and is almost reaching down into the pelvis. This is the stomach bladder proximity sign. And if you look closely, you can see the bowel loops in the thorax. Other important findings are upturned superior mesenteric artery. Normally, superior mesenteric artery has a downward course caudally to supply the intestines. So when there is a suspicion of intrathoracic mass or a mediastinal shift, the upturned course of superior mesenteric artery serves as a valuable sign in confirmation of CDH, especially in stomach down cases. And the lower image shows the mediastinal shift due to herniation of stomach, gallbladder, and small bowel in the thorax. When liver has herniated into thorax, portal vein and hepatic vessels can be visualized in the thorax. The image on the right side shows ductus venosus near the thoracic inlet. So what next? So this prenatal diagnosis gives an opportunity for in utero referral to tertiary care center for expert management. But what else do we need to evaluate? How much is the association with genetic abnormalities and which genetic tests to do? These are some of the common aneuploidies and Mendelian disorders associated with congenital diaphragmatic hernia. It includes full trisomies like trisomy 21, 18, 13, 22, 16, monosomy 15q, partial deletion or monosomy 4p, and overgrowth syndromes like Beckwith-Wiedemann syndrome, and pentology of Cantrell-Fryns syndrome. So all affected pregnancies should be offered invasive testing with CMA. There is a 10 to 15% risk of CMA abnormality in isolated CDH cases. And in cases of multiple associated structural anomalies, WES will increase the diagnostic lead. Coming to the antenatal prediction of postnatal outcome in CDH, the important predictors are antenatal diagnosis before 24 weeks, associated anomalies, especially cardiac, chromosomal abnormality, lung size, presence of liver herniation, position of the stomach, right-sided defects, and presence of polyhydramnios. The major determinants are associated anomalies, extent of lung hypoplasia, and liver position. Size of the diaphragmatic defect also matters. This was a case of large diaphragmatic defect and there was herniation of kidney into the thorax. This is confirmed by the visualization of renal vessels on power Doppler and the movement of kidneys in and out during respiration. The best predictor we use nowadays to assess the prognosis is the lung-head ratio. We find out the size of the contralateral lung and compare it with the head circumference and get a ratio. Now this can be done by either taking the anteroposterior and transverse diameters or by line trace method. Line trace method is considered to be better. But the LHR changes over gestation as lung area grows more rapidly than head circumference. So observed to expected LHR is taken, which corrects for gestational age. This is done using web-based calculators. The O by E LHR values, if it is less than 15%, it indicates an extreme pulmonary hypoplasia, and if it is more than 45%, it indicates mild pulmonary hypoplasia and a good survival rate. Liver position also determines the prognosis. Severity of CDH is estimated based on the binary variable of liver position, either liver up or liver down. In left-sided CDH, liver position is an independent predictor of outcome in addition to lung size, usually assessed by the O by E LHR values. However, in right-sided CDH, the liver is almost always herniated through the diaphragmatic defect. Therefore, liver position has little or no prognostic value. Because the echogenicity of the fetal liver is very similar to that of the lung, accurately determining the liver position and the extent of hepatic herniation into the thorax can be challenging on ultrasound. So consequently, fetal MRI is often more reliable for prenatal assessment of liver herniation. This is MRI of the CDH showing liver herniation. Liver herniation during breathing movements. Prognosis can also be predicted by stomach position as proposed by this Kitano classification. In grade 1, stomach remains completely below the diaphragm. In grade 2, it is anterior to the level of AV valve. In grade 3, it is at the level of AV valve. And in grade 4, it is posterior to AV valve or retrocardiac. Grade 1 usually has best prognosis, and grade 4 is the most severe grade, and it is strongly associated with significant pulmonary hypoplasia, liver up position, ECMO requirement, and lower survival rates. In isolated right-sided CDH, it is extremely difficult to diagnose by ultrasound if liver is the only organ that has herniated. Indirect signs such as a shift in the cardiac axis to left, deviation of the umbilical vein demonstrated in the cross-sectional view of the abdomen, identifying the gallbladder and vasculature in the liver using Doppler may aid in the diagnosis. Visualization of gallbladder in the thorax is a hallmark finding in right-sided CDH. This was a case of right-sided CDH with herniation of liver into thorax. Antenatal management depends on the severity. Termination can be offered in severe cases, or conservative management can be done in till term, or feto can be done. This feto procedure, fetal endoluminal tracheal occlusion, in this procedure, through a small trocar placed into the uterus, a fetobronchoscope is passed into the mouth of the fetus and into the airway. The bronchoscope guides the inflation of the balloon in the fetal trachea. The balloon is left in place, blocking the trachea, causing fluid to build in the lungs of the fetus. The accumulation of lung fluid in the occluded airway causes the lungs to grow and also reduces the herniation. So feto improves survival but increases the risk for prematurity. Effects are dependent on the time of tracheal occlusion. In severe CDH cases, it is done at 26 to 30 weeks, and in moderate CDH cases, it is done between 30 to 32 weeks. Feto may lead to iatrogenic death when the balloon cannot be timely retrieved. In this case, there was intrathoracic herniation of stomach on one side without significant mediastinal shift, and on further evaluation, liver herniation into opposite hemithorax was found. So this was a case of bilateral CDH, and It accounts for 1 to 2% of the total CDH cases, and they have the worst prognosis in view of severe bilateral pulmonary hypoplasia. An important differential for CDH is eventration. It is a weakness in the diaphragm, and it is more common on the right side, and it is not associated with severe lung hypoplasia. In this case, there was herniation of liver into the thorax. In parasagittal view, in cases of eventration, we can see the diaphragm as a continuous intact echogenic curvilinear line bulging into the thoracic cavity. Now, coming to intrinsic lung lesions, first we will discuss about CPAM, congenital pulmonary airway malformation. They are hematomatous overgrowth of bronchial tissue with absence or reduction of normal alveoli. They appear as cystic or solid echogenic lung mass with pulmonary artery supply. They can be macrocystic type measuring more than 5 mm, microcystic type measuring less than 5 mm, or mixed type. The more distally they arise, smaller the cysts or solid lesions, and they can cause hydrops due to compression. CPAM is of different types. These types are labeled on the basis of the site from where they arise. But this is a histological classification. The prenatal classification should be imaging based. So as a fetal medicine specialist, we need to correlate them. And this is the pattern recognition table. When there is multiloculated lesion with one or more large cysts, the prenatal diagnosis is macrocystic CPAM, and it corresponds to type 1 Stocker classification. This is the histological Stocker classification, and this macrocystic CPAM will correspond to type 1 Stocker classification. And multiple small visible cysts will correspond to type 2 Stocker classification. Solid highly echogenic mass is equivalent to type 3 Stocker classification, and single large peripheral cyst in echogenic lung corresponds to type 4 Stocker classification. Cystic lung lesion with systemic arterial feeder is a hybrid lesion which has features of both CPAM and sequestration. So this is a case of type 1 CPAM. There are large multiple cysts are seen. And this is type 2 CPAM, which shows mixed pattern with multiple small cysts. And this is type 3 CPAM with solid highly echogenic mass with marked mass effect. The natural course of CPAM is usually that the maximum growth is seen between 20 to 26 weeks. It peaks at 25 weeks and then plateaus. Most of them, more than 50%, resolve, and the risk for hydrops is more in CPAM. So the most intriguing question in CPAM is whether they're actually resolving. There is an argument that they're not actually resolving, but what is happening is the thoracic size is increasing in relation to that mass. And as I told in the beginning, the lung echogenicity increases as the gestational age progresses. So it can appear as if it is resolved. So therefore, in such cases, we have to rely on the mediastinal shift. And also radiological investigations after birth are important, especially postnatal CT. Risk of aneuploidy and syndromic conditions are extremely low in CPAM cases. So 50% of the cases, they do resolve. They outgrow their blood supply or spontaneous torsion occurs. This is probably the reason they resolve, and a resolution occurs in the mostly in the microcystic type with low CVR rather than the macrocystic ones. Risk for hydrops is much more in CPAM than other lung pathologies. As we already saw, CPAM increases in size from 22 to 26 weeks. So if a CPAM is sufficiently large at an earlier gestational age, it is associated with a higher risk of hydrops. And size of the mass is also important. It can cause compression of IVC and lead to hydrops, and this is not related to the type. This is a case of large type 2 CPAM with hydrops. And this is the post-abortal picture and the post-abortal X-ray showing hydrops. This is autopsy showing CPAM with fluid-filled cysts. The best method to evaluate the risk of development of hydrops in CPAM is the CPAM volume ratio, CVR. Length, height, and width of the lesion are measured and divided by head circumference. These measurements are to be taken in centimeter. And CVR should be measured at every visit because CVR helps monitor the size of the lesion. Coming to prediction of risk of hydrops in CPAM based on CVR, the magic number is 1.6. Value more than 1.6 indicates high risk and needs prenatal intervention. And less than 1.6 is a low risk of hydrops. Now, coming to the management, expectant management can be done in small lesions with no hydrops, decreasing or stable CVR, and minimal mediastinal shift. The best treatment for most CPAMs is careful observation. The next intervention is the maternal corticosteroid therapy. Indications for this are large microcystic or solid CPAM, CVR more than 1.6, developing hydrops, significant mediastinal compression. The standard antenatal steroid regimen given for lung maturity can be given for this as well. It reduces the epithelial proliferation, accelerates maturation of abnormal pulmonary tissue, and causes lesion shrinkage. The next intervention is thoracoamniotic shunting. The best indication is macrocystic CPAM with a dominant cyst. Under ultrasound guidance, trocar is inserted, a double pigtail catheter is placed into the cyst. And in CPAM, all cysts are interconnected. So the cyst fluid drains into the amniotic fluid, leading to decompression and reversal of hydrops. The other intervention is the exit procedure, ex utero intrapartum treatment. Indications are giant CPAM causing anticipated airway compromise, severe mediastinal compression, predicted inability to ventilate after birth. Here, partial delivery of the fetus is done while maintaining placental circulation and airway secured before cord clamping. It helps in controlled transition, avoids catastrophic neonatal hypoxia, and allows immediate airway surgery if required. The next thoracic anomaly is bronchopulmonary sequestration. It consists of an island of lung parenchyma that does not communicate with the bronchial tree and is fed by the systemic rather than the pulmonary circulation. 80% occurs on the left lower lobe. The sequestration, it follows the aorta, so it is usually in the left and posterior part. It is of two types, intralobar and extralobar type. In intralobar, it is within the normal lung, covered by visceral pleura of lung and drains into pulmonary veins. Whereas in extralobar type, it is outside the normal lung, has its own visceral pleura and drains into systemic veins. Infradiaphragmatic extralobar sequestration can mimic a suprarenal mass like neuroblastoma. So sequestration appears as a well-defined homogeneous echogenic mass usually in the left lower hemithorax. As I told, the diagnostic feature is the systemic arterial feeder. Here the lesion is supplied by branch of aorta. This clip also demonstrates its drainage into the pulmonary veins. Sequestrations are usually unilateral. The important differential is type 3 CPAM, which also appears as a solid triangular echogenic mass. The lower image is a case of type 3 CPAM, but it does not have the systemic arterial supply. Natural history of sequestration is much better than CPAM. In fact, 75% of them will decrease in size, and hydrops with sequestration is much rare. So sequestration is a better diagnosis than CPAM. But hydrops can occur in these cases because of the mass effect and also because of the AV shunt that occurs in large masses and can cause cardiac failure. The CPAM volume ratio can be used to predict hydrops, but is not as predictive as in CPAM, and it alone cannot be used to decide on any intervention. This is the risk stratification of sequestration based on the size of the lesion and presence or absence of pleural effusion, mediastinal shift, and hydrops. For high risk and very high risk cases, intervention can be done, and the definitive treatment includes the laser coagulation of the feeding artery. And the other alternative options are radiofrequency ablation, sclerotherapy, or thoracocentesis in cases of large hydrothorax. Laser successfully reverses hydrops in most cases. It significantly reduces postnatal sequestrectomy, and also lower rate of prematurity is seen compared with shunting. This report was published in May 2026 in ISUOG journal, and it supports the use of full laser ablation of feeding artery to avoid the need for neonatal surgery and prevent respiratory complications in non-hydropic fetuses with large sequestration, mediastinal shift, and bilateral pulmonary compression. In this study, out of the 23 cases which received the laser ablation of feeding artery, none of them required postnatal surgery. 6 cases required more than one procedure to complete full ablation. One case had preterm delivery and required oxygen support post-birth, but all other neonates were asymptomatic at birth. I request our moderator to share their experience on this, sir.
Yes, Shri.
Actually,
Dr. Sudarshan, have you...
Dakar से कहाँ कहाँ बात हुई तरफ को
Dr. Sudarshan, are you there? Okay.
Okay.
Okay, you proceed, Dr. Danya.
Okay, sir. Okay, sir.
लीव करने तो वापस ज्वाइन कर दे लफट हो जाएगा सही सिस्टम में अपना
So hybrid lesions are
अरे मैं देख ली तो छोड़ दो लीव कर दे सो जाओ अरे निकल जाओ काम की थोड़ी देर बाद घंटा बाद
Hydrops risk in these cases depends on CPAM component size and not the feeder. Coming to next thoracic anomaly, congenital lobar overinflation. There is overexpanded echogenic lobe without cysts and without systemic feeder. They are usually seen in the left upper lobe or right middle lobe. They have a normal vascular pattern, and CLO are often diagnosed postnatally. There is a cartilaginous deficiency in the bronchus, which causes the fluid to go in, but it cannot come out. So it keeps expanding like a balloon. So in this condition, it is not a mass, it is a lung segment that gets over distended because of a problem in the bronchus. Diagnosis is actually challenging prenatally. In early gestation, they mimic type 3 CPAM, but they progress slowly and do not cause hydrops, and there is no role of CVR or steroids in these cases. So an echogenic lung lesion without a systemic feeder with mass effect later in gestation after 28 weeks with mediastinal herniation, no hydrops, and postnatally there is progressive lobar overinflation causing respiratory distress, then the diagnosis will be congenital lobar overinflation, or previously called congenital lobar emphysema. The next lesion is chaos, congenital high airway obstruction syndrome, which involves the laryngeal or tracheal atresia. It is extremely rare. The 3 possible lesions are agenesis of the glottis, agenesis of larynx, or both. Impaired blood supply during the embryonic period prevents the normal development of trachea and larynx. Fetal hydrops is common with these cases, and they can be detected as early as 15 to 16 weeks. So there are bilaterally symmetrical, massively echogenic lungs with dilated trachea and inverted diaphragm. So this is a very unique lesion. Once seen, it will never be forgotten. And you can see that heart is pushed anteriorly and to the center. And in the top image, bronchogram, that is the abnormal dilatation of the bronchial tree, is very well seen. This image is of the same fetus showing the marked ascites. Can anyone tell what are the pointed structures in the chat box?
Okay, let them reply. You can proceed.
Okay, sir. So this was a case of chaos with non-immune hydrops. This is the post-abortal picture showing hydrops and autopsy pictures showing laryngeal atresia and fluid-filled enlarged lungs. The risk of aneuploidy in these cases is extremely low, but the risk of syndromic conditions are extremely high, especially Fraser syndrome, wherein there is also a renal agenesis. The prognosis is very poor, and the only available option for delivering a fetus with laryngeal atresia is the exit procedure. That is the ex utero intrapartum treatment procedure. In this procedure, performed during cesarean delivery, it enables interventions on the fetus while still connected to the placenta, utilizing feto-placental circulation for gas exchange. This approach is valuable in cases where the fetus experiences significant respiratory distress at birth. This is the classification of different indications for the exit procedure according to the intended intervention while maintaining the uterus-placental circulation. First is the exit to airways. This is the commonest indication and is performed when airway obstruction is anticipated at birth. And the site of obstruction can be extrinsic, intrinsic, or iatrogenic. Exit to resection. In these cases, the placental support is used to allow surgical debulking or resection of large thoracic masses before neonatal respiration is established. The other indications are exit to ECMO and exit to separation. Next anomaly is bronchial atresia. It is a rare anomaly wherein there is obliteration of segmental or lobar bronchus. Airway is occluded rather than narrowed. Fluid-filled lung distal to atresia is seen, which appears echogenic, and recurrent infections are seen postnatally. On ultrasound, a dilated tubular bronchocele with hyperinflated distal lung is seen. Usually, upper lobe is involved. Next anomaly is the bronchogenic cyst. It is a unilocular, anechoic, smooth-walled cyst in the mediastinum with no feeder, no lung distortion or mass effect unless large. So here we can see a tubular elongated cystic lesion seen in the upper lobe of left lung. Cyst is thin-walled and there is no mediastinal shift or pleural effusion, and spine was normal. The important differentials for bronchogenic cyst are esophageal cyst and neuroenteric cyst. So these are posterior mediastinal lesions. This was a case of tracheoesophageal fistula. We can see the blind ending esophageal pouch which is seen in the thorax. On fetal breathing movements, it produces intermittent color signals within the tracheal lumen due to movement of fluid and tracheal secretions, whereas the blind esophageal pouch does not demonstrate the color. There was also polyhydramnios and absent stomach bubble in this case. In case of neuroenteric cyst, they are located along the spine in the midline or paraspinal area and are frequently associated with vertebral or spinal anomalies. They have a strong relationship with the spinal column and it helps distinguish it from the duplication cyst. Here, two contiguous anechoic cystic lesions are identified along the thoracic spine. One located in the posterior mediastinal paraspinal region and thus another located within the vertebral canal. Whereas in bronchogenic cysts, they are located in the anterior mediastinum. They are closely related to the airways or the tracheobronchial tree and they are typically away from the spine. Coming to secondary abnormalities of the thorax, lung hypoplasia. It can result from the thoracic compression lesions or prolonged oligohydramnios sequence, reduced fetal breathing movements, or thoracic skeletal restriction, or it can also be a primary pulmonary hypoplasia, which is usually very rare and sporadic. The timing and duration of the insult are critical. The earlier and longer the restriction, the more severe the hypoplasia. So this was a case of unilateral lung hypoplasia with the displacement of the heart to the affected side. The final anomaly in our discussion is the abnormalities. It can be classified as anomalies of the bony thorax, which involves pectus deformities, sternal anomalies, and rib anomalies, or complex defects and syndromes involving major ventral wall defects, skeletal dysplasia-related abnormalities, and Poland syndrome. In deformities, there is pectus excavatum and pectus carinatum. In pectus excavatum, there is posterior curving of the ribs and is aggravated during fetal breathing movements. This deformity may or may not be symmetric. This case was given by Dr. Ravi sir. So the precise cause is not known, and it can be intrauterine pressure or abnormalities of the diaphragm or connective tissue disorders, or it can also be familial genetic predisposition. Mild to moderate cases are asked to live with it as they do not cause any significant problem. For severe cases, procedure can be done. The other pectus deformity is the pectus carinatum, wherein there is outward protrusion of the sternum or ribcage. The deformity is often called pigeon breast. Coming to the next abnormality, it is the number of ribs. Here we take the 3D of the spine. Usually we do not count the ribs, but when there are other signs, we have to. This case had clinodactyly. There was abnormal inward curving of the middle phalanx of little finger, and the number of ribs were 11. This case later came out to be trisomy 21. In this next case, this fetus had Ellis-Van Creveld syndrome. It had 13 pairs of ribs and polydactyly. Now coming to the complex defects and syndromes, under the major ventral wall defects, we have pentology of Cantrell. It involves midline supraumbilical abdominal defect, defect in diaphragmatic pericardium, defect in anterior diaphragm, defect in lower sternum, and cardiac abnormality. This video shows ectopia cordis. The fetal heart is completely outside the thoracic cavity due to defect in anterior chest wall and sternum. There was also defect in the upper abdomen causing herniation of liver. This is the defect with ectopia cordis and pericardial effusion. And this is the 3D demonstrating the omphalocele and ectopia cordis. The next complex defect is Jarko-Levin syndrome. Here there is vertebral segmentation abnormality and asymmetric rib involvement. There is close placement of the ribs at the costovertebral joints, and they are flared anteriorly, giving crab-like or fan-like appearance to the chest. Some other rare chest wall abnormalities that we may encounter, one of them is hemangioma, which is seen in the lower thoracic wall. And this was a case of large lymphangioma in anterior chest wall. This fetus also had lymphangioma in posterior mediastinum and the thighs. Posterior mediastinum and the thigh. And this is the 3D showing the huge lymphangioma. Thank you. The pleural lesions will be discussed by our esteemed speaker, Dr. SAIRA Sandeep. Thank you.
Excellent presentation, Dr. Dhanyashree. You have covered almost everything in the thorax and all the anomalies related to the lungs. And Dr. Sudarshan, are you there? Are you able to speak? Dr. Vijay Anand, are you able to?
I'm here, sir.
Yeah. Your opinion and your inputs, please.
Actually, it was a very good presentation covering everything, actually.
Okay.
But one thing that we see very commonly postnatally is CLE rather than other condition, CLO, congenital lobar overinflation.
Okay.
And that is, in fact, the easiest thing to identify with a chest X-ray that even we can do. Overinflation with mediastinal herniation and all those things. And that is what we encounter very commonly, sir.
Yes.
And one thing that I want to ask is how significant is liver herniations? Because most of the left congenital hernias that we operate, almost always the liver will be there in the thorax. Whether
Probably.
it's a good prognostic or bad prognostic, but theoretically, liver herniation is considered a bad prognosis.
Yes, it's considered as a bad prognosis. We have to look for the liver up hernia.
Yes, sir.
So,
But-
as far as ultrasonologists are concerned, sonologists are concerned, we have to look for the liver up hernia because it is a criteria for bad prognosis.
Bad prognosis. But most of the cases, we get to have the left lobe of the liver herniated inside.
Yes.
And probably they do well. That one thing. And similarly, the lung head ratio, to some extent, it correlates. But only thing that we find postnatally is the timing of diagnosis. Definitely, it has a good prediction value. But practically, I don't think other things we find it that much
Useful in a
useful
practical
predictor. Yes, sir.
management.
Yes, sir.
Dr. Sudarshan, your opinion on laser ablation of sequestration, feeding vessels in the sequestration. You can unmute yourself. You can unmute yourself.
Yeah, sir. Laser for sequestration, we have done for a few cases, and we do it only for a subset of patients where there are any findings suggestive of evolving hydrops, like any effusion comes up. If there is a sequestration with the effusion, then it is one indication where we go and do that laser. Recently, we had a patient where there was a sequestration. We were following up, and in one visit, the effusion came. They wanted to come back. Within 4 days, they came. Edema started developing, and effusion became much more significant. So, in those kind of cases where there is a rapid progression and with the development of features of eye drops, then and we are able to document a very good feeder vessel, which is accessible for doing that laser, then we do go ahead and do it. And we do that by simple interstitial laser method. We use a 18 gauge needle. We take it up to that feeder vessel, thread the 400 nanometer laser fiber through it, and then at 40 watts, 40 watts power, 1 or 2 bursts, it will just get ablated.
The one or two cases, what you did had a good prognosis?
Completely, because within a week, within 4 or 5 days, the effusion went away. And within 2 weeks, the edema also completely went away. And after that, the pregnancy went to term. Postnatally, the baby was seen by the pediatric surgeon at Chennai. And then he said that at present, there is no need for doing any investigations also, because the child is symptomatically, nothing is there. So they have just told them to follow up the child and probably get a CT done once the child is around 10 months to 1 year.
Same results are shown in the literature as well. They have got a very encouraging report on laser.
Correct. But the key thing is to having a very close monitoring to decide which one you need to put the needle in.
Okay.
Without effusion, nothing needed to be done. Most of them, nothing will be needed to be done.
Okay. Thank you, Dr. Sudarshan. I think you are going for a procedure now?
Yes, sir. I'm just stopped up for one.
Okay.
Sir.
Okay, then you can be in the procedure and let SAIRA present her case and then.
Yes, I'll be back, sir. Half an hour.
Yeah, be back. Yes, thank you. So let's now invite Dr. SAIRA SANDEEP, who is heading the fetal clinic at Coimbatore, and she had had her training, basic training with Dr. Bhupati Vijayaraghavan, and subsequently she had her intervention training with Dr. Manikandan. So she is polished in both sides, and so now she is heading the fetal clinic at Pandi, and let her invite her for presenting her presentation on pleural effusion from diagnosis to management. Dr.
Thank you, sir.
SAIRA,
Thank you, SFM, for this opportunity. Let me start with a case. This is a fetus at 23 weeks who came to us with a concern of fluid in the fetal chest. So this is what we saw when we examined the fetus. So now the real question is, where exactly is the fluid and what is the fluid doing to the fetus? Is the chest getting compressed? Is the heart getting pushed? Is there an impending high drops? Is the fetus at risk? Should we wait or act? With this picture, we will try to build up an algorithm for the diagnosis, triage, and management of fetal pleural effusion. The first thing when we see a fluid in chest is to identify where exactly the fluid collection is. In the first image, it's an axial section of the fetal chest. There is fluid on the left side, and you can see the lung is collapsed towards the midline. So in a pleural effusion, when the fluid is there, you can expect the lung collapsing towards the midline. Whereas in a pericardial effusion, when fluid collection is there, the lungs will be pushed posteriorly. So this is a basic difference how you identify a pleural effusion and a pericardial effusion. In our case, as you can see, there was left-sided pleural effusion, the lungs being pushed to the midline, massive mediastinal shift, the diaphragm was flattened. And there were signs of impending hydrops. As you can see, there was increased prenasal edema and subcutaneous edema. Our diagnosis was left-sided tension hydrothorax with impending hydrops. Why do we call it as a tension hydrothorax? Because there was diaphragmatic inversion, there was massive mediastinal shift, and the lung was collapsed. When we are counseling a pleural effusion, and if it happens to be a primary hydrothorax, our counseling will be balanced because primary hydrothorax carries a better prognosis. But how do we label that as a primary hydrothorax? To label it as primary hydrothorax, we need to have a thorough check on the fetus and we need to investigate the cause for the effusion. For that, we do a amniocentesis. In amniocentesis, we check for chromosomal aberrations and rule out infection. We do a diagnostic thoracocentesis. If the lymphocytes are more than 80%, we know that it is chyle leak and we need to have a close follow-up. With close monitoring, follow-up and intervention if required, most of these primary hydrothorax do well. Almost more than 90% do well. The key word in our counseling will be reaccumulation. In case the fluid is reaccumulating and causing pressure effects, we may have to do a in utero procedure, that is an intrauterine shunt. If the fluid is not accumulating, then we will wait and watch. Delivery should be planned in a tertiary care center where you have a NICU facility and a pediatric surgeon available. And most of this primary hydrothorax will have a spontaneous postnatal resolution. So in our case, we plan for thoracocentesis and amniocentesis. The QF-PCR and TORCH-PCR came as negative for the common aneuploidies and for the TORCH. Pleural fluid cytology showed more than 80% lymphocytes. So our working diagnosis became primary hydrothorax or chylothorax. Almost 28 ml of fluid was aspirated, and post-aspiration we can see that the lungs were completely expanded. We called her back in 2 days' time, and this is what we observed in the next scan. Here you can see the fluid has reaccumulated, causing tension. The lung is collapsed, massive shift of the mediastinum. In the coronal view, also the same thing is brought out with the diaphragmatic inversion. Because it is causing pressure effect, we planned for shunting. So all the hydrothorax are not for shunting. It should be a primary hydrothorax. When do we tell it is a primary hydrothorax? It is after ruling out all other causes by seeking for the etiology. And it should be hypertensive in nature. Hypertensive means not the fluid should be present, that fluid should be exerting pressure with mediastinal shift and diaphragmatic inversion or impending hydrops. And after the diagnostic tab, the fluid should reaccumulate, telling us that this is something which needs continuous drainage. Imminent hydrops is not a contraindication, bilaterality is not a contraindication, and the fetus should be less than 32 weeks of gestation. More than 32 weeks of gestation, the technical feasibility is little less because the thoracic cage will become more harder for us to pierce and get inside. So for this case, we placed a thoracoamniotic shunt, and you can see the 3D rendering of the shunt, which is beautifully placed in the subscapular area. The procedure and the shunt details we will see in the latter part of the talk. Post-shunt, the fetus did well. It was taken till term and delivered a healthy neonate. The primary goal of thoracoamniotic shunt is to decompress the chest and allow the lung to expand. Mode of delivery need not be changed. It is according to obstetric indication, and place of delivery, as I told earlier, it should be a tertiary care center where you have the neonatology team and pediatric surgeon available. And shunt has to be clamped at birth. We need to intimate the neonatology team attending the delivery that they have to clamp the shunt as soon as the baby is born. Otherwise, the shunt which held the baby in utero might cause trouble to the baby once it is born by causing a pneumothorax. Now compare this case. This fetus came to us at 31 weeks. We can see a fluid collection on the right side with the ipsilateral lung pushed to the midline. The same is seen in the coronal section with fluid in the inferior and lateral borders and the lung being displaced towards the midline. In this clip, we can see pleural effusion of the right side. This is a right-sided moderate pleural effusion with mediastinal shift with no hydrops. The antenatal management basically depends on the etiology and progression. When we are prognosticating pleural effusion, it is basically based on the etiology and progression. To understand the etiology, first we will have to do a amniocentesis, rule out infective causes and the chromosomal abnormalities, and you do a pleural fluid cytology to see the lymphocytes. If it is more than 80%, we are happy that it is a chylothorax. And we should have a close follow-up. We need to see them again after a week or two. 25 to 40% of them have spontaneous regression. In case it is progressive in nature, at that point we will have to think of putting a intrauterine shunt. This patient was not willing to go ahead with further investigations. So we called her back after 2 weeks. And in this clip, you can see in the axial sweep, the effusion has completely resolved. In the coronal sweep also, you can see that the effusion has completely resolved. This is the other end of the spectrum. This was a case of transient pleural effusion. The real art is to identify which fetus we can safely sit and watch or which fetus is unsafe to leave. But that does not always happen in fetal medicine. Pleural effusion is an entity with multiple etiology. The primary goal is to divide it into or classify it into a primary effusion or a secondary effusion. If it is a primary effusion, you need to prognosticate it well, because we are ruling out all other abnormalities. We are ruling out the structural as well as chromosomal abnormality. And if it is a primary hydrothorax, it carries a better prognosis. And fetal therapy plays a major role in primary hydrothorax. But if it is a part or parcel of another bigger disease, that is, if it is due to some secondary causes, then we need to have a individualized approach. This fetus came to us at 13 weeks with suspected large NT. We concurred with the finding of large NT. There was septated cystic hygroma and generalized subcutaneous edema. In the axial section, we can see bilateral pleural effusion with the lungs being pushed to the midline. This is the axial section of the fetal chest showing the 4-chamber view. There was chamber asymmetry. The left side was smaller than the right side, and there was retrograde flow in the transverse arch. This disease entity is completely different. This is part of a bigger disease spectrum. It is non-immune hydrops of early pregnancy. We offered her chorionic villus sampling, and the result came as Turner syndrome. When pleural effusion is part of other diseases, or the secondary causes, what we need to have in mind are the chromosomal ones, maybe a Down syndrome or Turner. It can be due to Noonan syndrome. It can be part of infection. If it is associated with hydrops, then we need to look for the genetic syndrome and other metabolic disorder. Why are we concerned when we see fluid accumulation in thorax? For that reason, any massive space-occupying lesion or massive fluid collection, in the prenatal period, it can cause hydrops and it increases the fetal mortality. In the postnatal period, because of the continuous mass effect, there will be lung hypoplasia and it increases the neonatal mortality. So the main management goal is to mitigate these two. I'll just take you through the basic steps of thoracoamniotic shunt. Pre-procedure planning is similar like any other fetal therapy procedure. We start with the maternal pre-medication, tocolytics, fetal anesthesia, and the maternal local anesthesia. All these remain same for any fetal therapy procedure. When you're planning for the access, always aim for a subscapular entry. So dorsal entry is preferred rather than anterior or lateral entry, because that is a place where the fetus can least search and find the shunt and pull it out. So always aim for a subscapular entry. And ideally, there should be a layer of fluid between the fetal chest and the uterine wall. If there is fluid between fetal chest and the uterine wall, the deployment of the outside coils will be much easier. The thoracoamniotic shunt has got 4 components. The first one is the 13G 18 centimeter ecotip needle with the trocar. There is a long guide wire. There is a 5 French positioner. It has got a flared end and a non-flared end, and it has got 2 markings. This is the first marking and this is the second marking. And then you have the double pigtail stent. The inner end, which has to go inside the fetus, is of single coil. The outer end, which will be outside the fetus, will have 2 coils. We insert this into the fetus, we'll have to load these 3 components in a correct order. So this is a positioner. The first thing is to thread the guide wire through the flared end into the positioner. Once the guide wire is threaded, the next thing is to thread the shunt into this guide wire. So start with the double coiled side and then the body of the shunt and the single coil side. And if you closely observe, there are small fenestrations in the shunt tip. So this will help in easy drainage of the fluid. So a correctly loaded device will have all these components in this order. This is the tip of the guide wire. You have the single coil end, double coil end, non-flared end of the positioner, first marking, second marking, flared end of the positioner, and the rear end of the guide wire. So after loading, the loaded device will look like this. So this has to be kept ready when you are removing the trocar from the needle. So first you enter into the amniotic cavity. Whenever you are entering into the amniotic cavity for any procedure, you should enter with a sharp jab so that you will not tend the amniotic membrane. And always aim for a subscapular entry because we need a dorsal approach to enter into the pleural cavity. Entry should be aligned with the cross-section of the fetal thorax. So in this video, you can see that after entering, we are trying to manipulate the fetus to bring it to such a way that we get a proper subscapular entry. Once the fetus is anesthetized, it will obey to us. So you can see the operator is trying to manipulate with the needle. Third thing is entry into the thoracic cavity. That entry also should be a sharp jab and controlled. If you are giving a slow push, you may not enter into the cavity. Rather, you will just keep pushing the fetus around. And why I say controlled entry? Because we are so close to the mediastinum. So we should not injure the mediastinum. And in this video, you can see when the trocar is taken out, there is a sudden gush of fluid. And the operator is occluding the needle hub with the finger. If we don't occlude the needle hub, the full fluid will escape out and it will cause a decompression of the target area. So the shunting becomes difficult. When the assistant is taking out the trocar, the operator should occlude the needle hub. Next part will be inserting our loaded device. So we know how to load and keep the device prior to taking the trocar. So once the trocar is taken out, already we would have loaded and kept the device. So that device is threaded into the needle. And you can see the first marking here, and this is the second marking. And once you thread the loaded device inside the needle, and once you see the guide wire coming out from the needle tip, the assistant slowly pulls back the guide wire and then pushes the device in so that the first marking will come just above the needle hub. So that is the first step. And then the positioner is pushed inside again so that the first marking comes inside the needle hub. And here you can see the deployment of the inner coil. In this video, you can see the loaded device is being pushed inside the needle, and simultaneously on the screen, we can see the guide wire slowly coming out of the needle. This is the guide wire which is coming out of the needle. Once the guide wire is seen coming out of the needle tip, the assistant will slowly withdraw the guide wire a little bit and further push down the positioner so that the first marking will come inside the needle hub, and we can see the deployment of the single coil inside the thorax. The second step of the procedure is a withdrawal technique. By withdrawal technique, we will be deploying the outer coils. So for deploying the outer coils, what we do is we will slowly and gently take the needle hub towards the second marking. You need to turn and slowly take out the needle out so that the second marking comes inside the needle hub. If you see, the operator is slowly turning and taking the needle out. And the second marking, and he takes it out till the second marking is inside the needle hub. Simultaneously, on the screen, you can see the outer coils are getting deployed. The double coils will be deployed outside the fetal chest. And as soon as the coils are deployed, you can see the sudden gush of fluid through the coils. This is a sudden egress of fluid from the chest cavity. The key points in the procedure are, one is subscapular placement of the shunt. Always aim for a dorsal entry, subscapular position, and there should be little bit of fluid between the fetal chest and the uterine wall so that the deployment of the outer coils becomes easy. Second point is, when the assistant is taking out the trocar, the operator should immediately close the hub of the needle with the finger. So finger occlusion. Otherwise, the fluid will get drained out. There will be decompression of the target area and shunting will be difficult. Third is late loading. The late loading means you need not load the entire shunt pre-procedure itself, but just before you take out the trocar, you need to thread in the shunt into the guide wire and keep, so that there will not be any loss of memory. This is a 3D rendered image where you can see the shunt is placed exactly in the subscapular region. The take-home points are, when you see a fluid in the chest, first localize it, whether it is a pleural or a pericardial effusion. In pleural effusion, the lungs will be pushed to the midline, whereas in pericardial, the lungs will be pushed posteriorly. Primary hydrothorax has better prognosis, but how are we going to label it as a primary hydrothorax? It is after thorough check of the fetus, rule out all the structural abnormalities, investigate the fetus for etiology, rule out chromosomal abnormality, infective etiology, then it becomes primary. If it is part of a bigger problem, that is, pleural effusion is caused by some other reason, then you need to individualize the approach. Fetal therapy plays a major role only for primary hydrothorax. All fetuses are not for shunt. A shunt fetus is a fetus with the primary hydrothorax showing pressure effect. Pressure effect in the sense there should be features of mediastinal shift, inverted diaphragm with collapse of the lung or impending hydrops. And once you drain the fluid and again it is reaccumulating, telling that there is a need for a continuous drainage and the fetus should be less than 32 weeks of gestation. And delivery should be planned in a tertiary center with neonatology and pediatric surgery support. Thank you.
Excellent, Dr. SAIRA. This was a lucid and very clear presentation of your pleural effusion and the procedure. It was clearly explained.
Yes.
Dr. Vijayanand, are you there? Dr. Vijayanand? Dr. Sudarshan? So,
Yes, sir.
Sudarshan, are you there? Yes, Vijayanand?
I'm here, yes, sir.
Sir, is in a procedure, sir.
Okay.
Okay.
So, any questions from the audience to Dr. SAIRA? She has very clearly explained the placement of shunt, double pigtail shunt for the pleural effusion. All the steps are clearly explained. Dr. Girish?
Yes, sir. I have a question, Saira. If you, by chance, put the whole shunt inside the fetal thorax, what will happen?
So actually, even if we put it in the correct way, there is a chance that the shunt can migrate in 10% of the cases. So shunt migration as such is not a problem. We may have to plan for a reshunt. And there is a paper from the Greg Ryan group where they have specifically studied on a migrated shunt into the lung. And they have mentioned like a 22-year-old person still living with a shunt inside his lung.
So that shunt has to remain inside, isn't it?
It can remain inside, but in my personal experience, sir, when we did for a dominant cyst for a CPAM, the shunt migrated in the first attempt after a week's time, and then we had to reshunt it. But that baby got operated postnatally because the baby had a respiratory distress. At that time, they took out the
Shunt.
migrated shunt. Yeah.
Surgically. Okay.
Both the speakers had a marvelous presentation.
Thank you, sir. Thank you very much.
Sir.
And the previous first speaker, I would like to comment because I was deceived in any CPAM, no? I always put a diagnosis of that lobar inflation, no? Hyperinflation. Because in our one patient, I had put a CPAM and post-birth, it was one bronchial obstruction leading to hyperinflation. It was not actually CPAM. So I always put a differential diagnosis rather than the single diagnosis in case of microcystic CPAM.
Yes.
Okay, sir.
Otherwise, both the speakers really did fantastically well.
Thank you, sir.
Somebody has asked, Madam, where do you buy shunts? Where it is available? How to order shunts?
Shunts are difficult.
Widely available in India nowadays. We have some good friends when they come from abroad, we source it from them, sir, or from CDSCO, that portal we can apply, sir, or through Cook Medical we can apply, but it takes a very long time. We cannot use it for the patient right away.
So when it is needed, it may not be available.
Yes, sir, yes, sir. It takes a long time. Once we apply, it takes weeks for us to get a reply from them.
By anesthetizing the fetus, you mean the corerization?
Sir?
You mean by anesthetizing fetus, you mean the pancreonium?
Yes, sir, yes, sir. We give atracurium to deltoid or thighs.
Yes. And so there are no more questions in the chat box. What, Dr. Dhanyashree, you pointed out something and asked what it is. You can go. Can you go
Yes,
back
sir.
to your slide and?
Yes, sir.
Vijay, how your comments on Dr. SAIRA Sandeep's presentation, please.
Actually, it was a very good presentation, sir. It was something that was new for us to watch.
Very
Actually,
good.
we learned a lot. Actually, the way the procedure is being done actually minimizes our job. The complications are significantly reduced with the early intervention and proper management of these children and the fetus.
It was very simple to look at, but when you're doing definitely there will be a lot of practical difficulties. Unless you have done few procedures by yourself, you will not be able to do it in the way that they are doing.
Even doing it directly on the children is very difficult, sir. Doing it through the mother's womb, a fetus is definitely, we can understand.
And
That's
she has
a real
clearly
good job.
explained that when the fetus is being delivered, it has to be clamped so that the pneumothorax doesn't develop.
Just like we have this ICD tubes connected to underwater drains and other things, it has to be closed properly. But we should be aware of those things when we deliver the children. That's a good message.
Somebody has asked about atracurium dose.
Atracurium, sir, we take 1 ml, then dilute with 9 ml, and from that mixture we take 1 ml and then give it to the fetus.
Okay. Okay, Dr. Dhanya, you can show that. That's it. Are you able to share? That was also my question. Where to buy shunts? I'm actually looking for shunts to train myself.
Is my screen visible, sir?
Yes, yes.
So my question was, this was a case of chaos with hydrops. This was the right image. It is of the fetus with the marked ascites. So can anyone tell what are the pointed structures?
You tell the sex, they will say.
I think someone has replied in chat box.
No, I think it is different. They have asked a question, they have not replied.
Okay, sir.
What is the most important ultrasound parameters for predicting prognosis in CPAM? Dhanyashree. You can. What is the most important ultrasound parameters for predicting prognosis in CPAP? Hello, Dr. Dhanyashree, are you there? Dhanyashree, unmute
Hello.
yourself.
Yes, sir. Can you hear me, sir?
Yeah, I can hear you. What is the most important ultrasound parameters for predicting the prognosis in CPAP?
The CPAM volume ratio, CVR
CVR.
ratio,
Yes.
is the most important parameter. And as I told that the magic number is 1.6. So if it is more than 1.6, it indicates high risk and high risk for development of fetal hydrops. This CPAM volume ratio can be calculated by that length, height, width, and of the lesion and divided it by the head circumference.
As Rupal Patel has asked, if bilateral hydrothorax, then two separate trocar entry need for bilateral shunt. He is asking. Dr. SAIRA?
I think, sir, if the fetus can be manipulated with a single trocar entry, we should try to manipulate the fetus. Definitely, we will need two shunts and two introducers to be loaded and kept. But with a single trocar entry, we should try to manipulate the fetus and get the fetus into position.
I think
Because
with
anyway,
people
the
like
fetus is
you,
anesthetized.
with people like you, it may be sufficient with one trocar entry.
So to minimize the risk.
Okay. If bilateral hydrothorax, then two separate trocar entry is needed for. That's the same question again showing up. Anything else?
The question to the first presenter, sir, how significant is microcystic and macrocystic CPAM in predicting the prognosis?
As Dr. Girish Patel told, most of the, as you also told that most of the microcystic CPAMs may represent CLO.
Yes, sir.
So if you're getting it typically at the lower lobes and wedge-shaped lesions and don't have a systemic blood flow, then we can say the differential diagnosis, as Dr. Girish told. It can be microcystic CPAM, it can be also a CLO.
Yeah.
You are asking about prognosis, Vijayan? You have to tell.
Prediction of prognosis, yes, sir. How to prognosticate antenatally?
The same, sir. See, CVR.
Okay.
CPAM volume ratio.
Because somewhere I read microcystic more often regresses and macrocystic usually will be persistent, and that's what.
Yes. Microcystic is the one which can regress antenatally.
Antenatally, yeah.
We have to follow it up, and the regression may not be true regression. We'll have to follow it postnatally also with other radiological investigations like MRI.
Okay.
So thank you. If there are no other questions, I think Sudarshan is also held up in a procedure. Thank you very much, Dr. Vijayanand, for your valuable sparing of your time among your
busy schedule. It's a pleasure to watch all these things, Uncle.
Among your busy schedule. Thank you very much. And thank you for the presenters, particularly Dr. SAIRA SANDEEP, who has patiently and very clearly explained the procedure to all of us. And we give her a warm applause for her. Thank you.
Thank you so much, sir.
Thank you. And Dr. Dhanyashree also, you did an excellent job by presenting all the gamut of thoracic anomalies. Thank you very much.
Thank you, sir.
Have a great weekend. Thank you. The arrows pointed to the testis. It was a male fetus, so it was the intra-abdominal testis. The gestation age was less than 23 weeks. So the arrows pointed to the testis. Dr. Rajani Soni has asked what are the arrows. Answer for the spatter, Nicola has also asked. The answer is testis in the abdomen, intra-abdominal testis. Intra-abdominal portion is testis. Undescended testis. So thank you very much, all of you. Have a great weekend.